are an ACLS team leader who has been presented with a conscious and alert 55-year-old male. As you interview the patient, you ask him how he's feeling. The primary assessment reveals that he is responsive, has an open airway, but he's experiencing shortness of breath. You learn that the patient was watching TV when the symptoms started, and that was about 3 hours ago. The patient is now complaining of chest pain, pressure in the chest, shortness of breath, and you can tell he's very diaphoretic. We know that the patient has a pulse and is breathing, so the next step is to check more in-depth vitals. As the team leader, you ask another available team member to attach the blood pressure cuff and place the patient on an O2 saturation monitor. A more detailed pulse check is taken and a respiration rate and temperature is assessed. Now, even before vital signs are recorded, a first drug may be given to a patient with a suspected heart attack. And that first medication is aspirin. First, you'll want to ask the patient if they have any allergic reactions to aspirin or if the patient has problems with gastrointestinal bleeding. If the patient responds yes to either of those questions, then aspirin would be contraindicated. But in this scenario, we're going to say that the patient does not have any allergies and there are no gastrointestinal bleeding problems. In this case, the correct dose is given between the range of 160 to a 324 milligram of chewable aspirin. In our scenario, we give the patient 324 milligrams of that chewable aspirin. The team member now has the vital signs and tells you that the patient's pulse is 124 beats per minute. It's regular while respirations are at 22, and the blood pressure is 140 over 90. The skin is cool and pale, and the O2 sat is 92%. Now, based on this information, we decide that the patient is stable at the moment. But one thing to keep in mind is that the goal for oxygen therapy is to titrate that amount of oxygen in order to achieve at least 94% saturation. It's not necessary and is potentially even harmful to use high-flow oxygen to bring the O2 sat higher. High-flow oxygen therapy can reduce cardiac output and stroke volume. It can cause vasoconstriction at a time when we especially need vasodilation. Oxygen is not recommended for an O2 saturation reading that is 94% or greater. Now, since our patient has an O2 sat of 92%, it would be appropriate to start a low-flow oxygen dosage via nasal cannula. So we're going to do that at between 2 and 4 liters per minute. Now that the basic vital signs are known and the oxygen has been established, it's important to get a 12-lead ECG on this patient. Now, this is going to help us in assessing the need for fibrinolytic therapy. Within the first 10 minutes of being seen by a healthcare provider, a 12-lead ECG, targeted history, and a physical exam all need to be done to assess whether or not fibrinolytic therapy is appropriate. Now, when assessing the 12-lead ECG, an ST elevation or depression would create a strong suspicion for injury or ischemia. In our scenario, however, it looks like a normal sinus rhythm. And at this time, it's now going to be important to gain IV access and draw blood to send to the lab. A good choice would be an 18-gauge IV with normal saline at TKO rate. Since the patient is still having chest pain and the blood pressure is above 90 systolic, nitroglycerin should be administered. Before giving nitro, it's important to ask if the patient has taken any erectile dysfunction drugs or any other medications that would behave like a vasodilator within the last 24 to 48 hours. If the patient has, nitro would be contraindicated. Now, if the patient can have nitro, it's given in a 0.4 milligram tablet or spray sublingually, and it can be repeated every 5 minutes for pain as long as the blood pressure remains above 90 systolic. You would tell the patient that you're going to give a tablet of nitroglycerin to dissolve under the tongue and that it should help with the pain. It wouldn't be wrong to tell them that they might even develop a little bit of a headache with it, or that it tingles under the tongue, and those are normal side effects. It's important to monitor the patient closely to look for changes in status. The level of the chest pain and the blood pressure need to be assessed at least every 5 minutes in order to consider additional doses of nitro. In our scenario, the patient's pain is still at about an 8 out of 10, and blood pressure is 120 over 88. It would be recommended to administer a second dose of nitro at 0.4 milligrams sublingually. It would also be appropriate to run another 12-lead EKG to see if there's any changes. The most important interventions early on for acute coronary syndrome patients are to provide adequate oxygenation, administer pharmacological interventions to reduce pain and anxiety, perform a timely assessment using a 12-lead EKG, history, and blood labs. The patient needs to be evaluated early for the possibility of fibrinolytic therapy. Cath lab considerations for percutaneous coronary interventions, known as PCI, or to be transferred for continued care at a cardiac unit.